Okay. So, do we have, if you turn your table tent when you speak, just identify yourself and use the microphones, please. We'll start here with Joanne, then come to Lucy, then Bruce. So 1, 2, 3.
Two quick notes. One is that death awaits us all, and in some of their populations that are high cost, death is somewhat closer, and the bundle goes from now to the end of life, as do the measures. And we have failed in, I think, three serious methods issues that we really need to double down on. One is that we've made the rational assumption that is wrong, that what we do doesn't affect the timing of death. So if people were in a care system that yielded on average 1 month less survival, it would improve all of the measures we now measure in CMS: pressure ulcers, pain, costs, caregiver burden, everything. This becomes more of an issue as we get more and more choices to shorten life in the population. But there are choices to shorten life in everybody's care. So it's a serious issue that we have managed to dodge. A second one is that people routinely go across all kinds of settings. And while it's in the list that Patrick and others published, we don't do population-based metrics. So the conversion of maternal infant well-being from kind of a family issue to a public health issue actually was mainly around generating infant mortality rates for geographic areas. We have no similar metric at all for serious illness and old age. So we can't say whether things are getting better or worse in Washington or Springfield or anywhere else because we can tell you whether this nursing home's bad, but we can't tell you whether a community is doing better or worse. So we nearly need some public health measures. The third thing is that we are sloppy about our cohort definitions. So people will say, 5% of the population is spending whatever percent of the money, and we don't know right off whether we're talking about nursing home costs as well or not. And it usually takes deep digging to figure out what this data source came from and whether you've excluded people who can't use the telephone or people who are in institutions or various other populations. And I think we really need to be really careful about the cohort definitions that we're using because we can really be seriously misled. So if we clean those up as well as the ones you've put out on the table, we would have one heck of a measurement system.
Yeah, those are great points, Joanne. I'd like to respond to the cohort issue because I think it's a really important one, and I think we've had a really hard time even defining the population we're talking about today, and we spent a good portion of the morning just trying to think about how we even define them. Think about what measures would look like. How would you define the denominator of those with advanced illness care at the highest need? And I think there's an opportunity to do some of those intense data analytics now. We've just done some of that with our incubator and some folks at Hopkins and Optum Labs to begin even establishing who's the group of patients who would most benefit from home-based physician care, like we heard this morning. How do you define that population? A combination of natural language processing and a whole series of different ways, and we've at least come up with a denominator on which to build the measures going forward. I think there's an opportunity to think about how you use data to do that going forward as well on some of these other really complex issues. I mean, it's not even clear who patients who need palliative care are, if you want to begin defining them. So I think there are some real opportunities to use the improved analytics at our fingertips that are often longitudinal, claims-based, plus EHR to really make a dent in some of the cohort analyses.
Just, Joanne, your point about end-of-life measures, I second and third and fourth for a variety of reasons. One of which is around trying to get payment right to Medicare Advantage plans, so that I and others have worked for many years on trying to get risk adjustment right. By far the strongest and easiest way of getting payment much closer to right would be to pay based on the fraction of beneficiaries who die. so that plans that have more people dying should get paid more, and plans that have fewer people dying should get paid less. That, of course, in the context of death panels in particular, is a political non-starter, but might be possible if we really had robust measures of the quality of end-of-life care that we could rely on and believe in.
And I'm going to stay away from the death panel thing. However, just to point out, I mean, we know a lot about what we can measure, right? And the challenges that we've had are that we have our legacy systems where you focus on nursing homes or you focus on home health agencies. For the first time, we actually have and will have alignment of the actual data elements across much of that, and yet it's still only about those who are receiving services. So I think we just have to, know what we know, but be clear about the bias that our observation puts in front of us, because and just to say it, this population, we can know a lot about those who receive services, piece together the administrative claims and such. What is not on the map is all the care and services that are provided by people who don't receive payment for it, right? So, and I think we also have to be careful about when we talk about savings, we to also have a limited scope, because it might be savings to one program or another and still not being able to measure where that is going or deflected upon. So I think it is a data issue, but I think it's also being able for us to state what our assumptions and limitations and what we know and what we don't know.
So here and then to Bruce. So Lucy. So.
Hi, I'm Lucy Savitz from Intermountain Healthcare, and thank you to all of the speakers. I think you've made a lot of really important points. Speaking from a delivery system perspective, and having spent the last 5 years trying to harmonize patient-reported measures across the delivery system so we can get some meaningful information, a couple of things. One is we need to be cautious in how we move forward. Because there's not been enough research done to help us realistically interpret changes in a lot of these measures. So when does it require a therapeutic response from a clinician, for example, or have they really made improvements when somebody started out at a much higher level of wellness versus somebody who is experiencing, multiple chronic conditions. And so our ability to interpret the information either from a clinical perspective or a value-based purchasing perspective, I think we need to know a lot more about that. The other thing I think is important is as we move into these new risk-based payment models and we extend the care continuum that includes community dwelling and community-based organizations, having at least a small set of standardized measures that are germane in the community as well as in the care delivery system so that we're looking across a continuum and across a lifespan for people's experiences.
One quick comment on the PRO space, and I'm glad you brought that up, Lucy, because it's really a challenge. I think we have to, as a community, figure out there's two poles, right? One of which says the measure could simply be that the healthcare delivery system collected the PRO data, right? On an annual basis, you've collected PRO data on patients with X. The other extreme is you'd say you're going to hold the health system or a clinician or other accountable for the percent improvement, which may not always work. And I think we as a community need to figure out what's between those two poles. How do you meaningfully use those data in a way that drives improvement? And it doesn't always have to be percent improvement, but it's probably not enough to say you just did it.
Great. So I want to pick up on the last comment and share your comment. And this may all sound a little heretical, so just bear with me. My problem with all this is it feels incredibly incremental. And I get that it's really difficult and we need to measure and we need to test to the point that it's proven, but we're building measurement systems for the sake of payers and providers. There is almost nothing up here that's meaningful for a person. I'm sorry. It is almost irrelevant for people. And that's why quality doesn't really drive people's decision-making or selection very much. And so I guess the question I would have is, well, and the other observation I'd make is trying to understand, and Sherry, it's the point that you made, which is totally right. Looking at Medicare claims data to understand this population when there's no functional information is ridiculous on the face of it. I mean, you're sort of parsing light under the lamppost because there's light there. So, you know, I think the challenge is there needs to be some bold leadership, and I don't know whether it comes from, you know, inside CMS or from the quality agencies, but we need to begin to measure things that count, like function. Function would dramatically change how we think about these patient populations. But CMS has sat on the CARE tool for years and years and years. And I'm not asking you to speak to it, but CMS people would say, oh, but it was never really meant to be used in this way. And that may be true, but the idea that there would be a tool that's useful not just in the post-acute setting, I mean, those are all incredibly medical. And I would say even in the duals pilots, if there had been a common initial health assessment or a small set of initial health assessments that people were asked to pick from or modify from, we would have a different data set than we do today. So there has to be some commitment to move out of incrementalism and at least try. It goes to what you were saying, Hal, which is we ought to have a small set of measures and just ask people to start, because I don't think until you start, you have to take something away. If you've run an organization, there's already too many measures. Because I'll flip this on its head for a second, and I just want to challenge all of us in the room. This is the kind of thing where some smart 20-year-old, I mean, the data in everybody's hospital systems belongs to the patients. And the days of it living on dead trees is ending. So this is, and there's already lots of yelping of doctors and hospitals and whatnot. So we all ought to be mindful that while we're sort of incredibly incremental in our thinking about quality, no other industry thinks about quality this way. And I think this is the place where somebody could step in and completely take it away from the regulators, from the providers, and start to use data in different and potentially very challenging ways that none of us in the room might like, but it's our own fault that we didn't provide better data.
I would just say, Bruce, that I think you're right, but when you say no other industry thinks about quality, it's probably not the case in no other industry. I work in universities. But many other industries don't think about quality this way. But I think you should be thinking, as I suggested in that one slide, about why and what's the reward to thinking about quality in this way. And I think that that's actually a bigger part of the problem.
And also, reward to whom? So, and I think that's an important point, because when we think about and implement quality programs, it is to fulfill a requirement, right? It's expected, and we have a deadline to do so. But that's not to say that the work that we do to fulfill those requirements cannot support measurement for other purposes. I mean, the fact that we actually have standardization of important elements of function through the Impact Act, and thank you for all of you who have worked on the CARE tool, because it was the foundation for all the work that we are doing now. And it certainly can be used in different ways. And the fact that it aligns with those same domains and elements of the PROMIS tool and has common roots, you know, we're creating opportunities to collect patient-reported outcomes, because that is the one constant across care settings, right? It's the patient, it's the person who receives that care. And we can't assume that what quality looks like for an individual facility at that point in time is actually going to be identical to what matters to patients, because we can measure it. So we take your points very well, but I think there is opportunity. Unfortunately, it has been very incremental, but I think the opportunities are actually before us. So thank you.
And just one quick thing to add, I think that it's time for a really disruptive force in measurement, and I completely agree, and that's been part of our thinking about the incubator, and really we have to just redo this model. We can't wait 3 years for an outcome measure. We're at a point now where we need to really have a much more dynamic, agile process that's responsive to the needs of the end users, which is why we need feedback. And just lastly, we're actually very pleased that we've got a grant from Susan and the Robert Johnson Foundation with Patients Like Me. You know, you talk to patients, and they can be a disruptive pushing force. They want somebody to look at their function. They want somebody to understand. I was telling an example earlier to Susan, some work we're doing on PROs for COPD. The number one symptom patients with COPD are most bothered by is insomnia, not cough and shortness of breath. You wouldn't know that unless you went to patients. So I think the patients is the disruptive force here, and also clinicians buy that data as well. I think it could be a really powerful force, because you're absolutely right. It's time to disrupt.
Okay, now we're going to do our 2x2 to keep, because we're getting close to the end of time. So we'll do 2 at this table, 2 here, and then come to Susan, and then we'll wrap up. So start with David.
So David Dorr
Introduce
from
yourself. Perfect, thanks.
David Dorr from Oregon Health and Science University. I'm an internist and informatician, so measurement and the care of people who have high needs are really important to me. And as we were going through the taxonomy, what kept recurring to me, and as you were sort of talking, is we could create a lot of measures. We already have a lot of measures. This has been something that's sort of ongoing, but I feel like we lack the discipline to be parsimonious in applying them, that when we start to develop new measures, we should think about repealing them, bringing some back, or not using some. And I wonder, how do we get the discipline? Are there opportunities or examples where you've seen this be really effective? I heard a little bit about the duals. We ask a lot in the HRA. Is that going to be an example where we say we don't need to ask so many questions? Because I think the burden of asking all these things can be pretty high and can limit participation and engagement.
Richard Frank from Anthem. So we do some measurement of patient behavior. So for those of us who get commercial health insurance, we'll oftentimes get an incentive if we stop smoking or we lose weight or we get immunized. And so I'm wondering if the panel has any interest in, thinks we can measure patient behavior, and even more potentially provocative is provide incentives to change that behavior. Because in my world, getting engagement from the patient for any care management program you design, no matter how wonderful it is, tends to be very, very low.
So measure, yeah, we're going to ask you these 2, measure retirement and engagement strategies.
So to address the measure portfolio refinement, I think it is a necessary part of the normal practice of consideration of measures. And in fact, that is something that is done through the Impact Act, the MUC list, the measures the measures application partnership, and the measures under consideration list. It is necessary to review the portfolio, what is topped out, what still has room to improve, and that those that are topped out could be actually removed or retired from implementation. Now, having said that, so that is the process that CMS engages in. There also can be, since measures are not just used by federal programs, but for quality improvement purposes and the like, there is a eddy current that can happen, and we believe is happening even outside of that federal formal process, that I think it is part of refining and focusing and coming up with and maintaining a parsimonious set of measures.
Yeah, and just to build on that, so a lot of the work of the map that NQF oversees is looking at all the measures and federal programs and making recommendations. To date, it's been mainly focused on the new measures coming forward, and we've been working with CMS to make it clear that from this year going forward, we're also going to have those groups look at the measures in the program and make recommendations of which ones potentially could be moved out in the future. Again, with rulemaking, there's often a significant lag, but at least start that discussion. And we've also beefed up our criteria on measure endorsement, that if a measure's been out there for a long time and it's not driving improvement and people aren't using it, we're just going to start taking it out of endorsement and moving it out.
I guess very quickly to Richard's question, certainly if there were large and relatively stable populations of people in health plans or in medical groups, and if we had good methods of doing risk adjustment, then trying to at least report on, if not pay for, reductions in smoking and reductions in obesity, in theory would be a great thing. Those are really big ifs, and as you know, a tremendous amount of turnover from year to year makes it hard to do attribution really well. Our ability to do risk adjustment on this stuff is not so good, so it's kind of tough. But at least reporting would probably be a good thing. I mean, again, I think that reporting is a start, and clinicians and plans don't like to look bad, even if there's no payment involved.
So let's take these two questions as the last two, take them together.
Lynn Quincy from the Policy and Advocacy Arm of Consumer Reports, where I direct the Healthcare Value Hub. And I actually have a response to Dr. Frank, because what I heard you say is pay patients to adhere. And I think our evidence is getting very, very strong that will not work at all, because we have tried it. And, consumers already have an incentive to get to a good outcome, a very, very strong incentive. So what we really have to do is look at the barriers that are getting in the way of getting there. I mean, they want good health. Their incentives are going in the right direction. So, but I totally discourage that as a profitable avenue. My swinging back to the providers and paying them, I really appreciated Dick's comments about, maybe I think we're putting too many eggs in the provider payment reform basket, and we really do need to look at these other ways of driving quality. I think that trimming the bottom is extremely, obviously consumers want that. They don't want to have to navigate a healthcare landscape that is not safe for them and has poor performers. And in the real world, it's actually exceedingly difficult to do that because of professional society pushback. So, and I do agree with Richard that the sort of appealing to professionalism, providing them with a pathway to get to better treatment patterns is the way to go. And my question for the panel is, have we under-researched those two ways of getting to better quality because our focus is too much on provider payment reform?
Hi, my name is Nancy Miller. I'm at NIH. I just had a couple of brief points I wanted to make. One was, it seems to me that one of the most important, if not one of the least politically feasible things that we could do to really better understand this high-need population is to be able to collect data on them longitudinally. And with the amount of churn going on with folks in and out of Medicaid, in and out of health plans, it's almost impossible to do. So we have an incredibly, as folks have said before, fragmented system. If there might be the potential for this group to make a recommendation to the administration to develop a unique patient identifier, taking into account all the issues about security and safety, I think that might be something that could substantially move all of us forward to much better be able to characterize these patients and to be able to predict how they do over time. So that's one question. Another question has to do with the role of ONC, the state of our electronic health records, the lack of standardization and interoperability, and the importance of being able to actually depend on that information, were it to be standardized, to drive our understanding and our capacity to predict how well these patients are going to do. So another possible recommendation might be to actually suggest that ONC utilize much more of the powers that it has to move forward in this space. A final question has to do with the role of the rapidity of the changes that are coming in the payment system, with the payment for value of care, and the impact on our primary care docs, on our specialty docs, the high rate of anxiety, of individuals leaving the field, burnout, and also linked with a number of measures docs feel they have to fill out. I'm wondering whether CMS has been doing any research on this. I'm wondering also NQF if there has been any effort to talk more with ONC. So those are just a couple of
Okay.
short questions.
There's a lot there, so why don't you take?
I'll take Lynn's question very quickly if I could. It sounds like there is a right answer. The answer is yes. I return, I mentioned very briefly when I was talking, I think one of the really notable successes in the quality space in the last 5 years has been the improvement in safety in hospitals. So I said, 17% improvement. We went from 145 adverse events per 1,000 hospitalizations in 2010 to 121 adverse events per 1,000 in 2014. 121 adverse events per 1,000 is still way too many, but it's a lot better than 145. And we don't know exactly why that happened, but leading hypothesis is that the Partnership for Patients effort at CMS, which provided a lot of technical assistance to hospitals, was a very important part of that, as well as perhaps a payment piece in hospitals getting penalized for having a lot of adverse events and getting attention. But certainly the providing of technical assistance and feedback of information is, I think, an underutilized mechanism of quality improvement.
And actually, to build on that, so we know that measurement in and of itself is insufficient, but required, that you need the skills and the will and the time to apply your best evidence to improve as well as measure in small tests of change. And we also know that the previous state of volume-driven medical care and services was particularly hard on primary care and on practices in general. And hence, if you actually look at the model test, which is called Transforming Clinical Practice Initiative, it does a couple of things. Number one, it does focus on practice redesign, provides tools and an entry into a community to learn about practice redesign in a way that is more person-centered, but provides continuity over time for patients, but that practitioners also enjoy. They like to get feedback. I, as a physician, like to know, did I do the right thing, or could I have done a better job? Having information like that helps inform what you do in the future. Now, that also requires, though, the time, the skills, and the will to do so. And part of the practice redesign and the change package also includes some best practices for reintroducing joy at work, as an example. It's one of many that it would be well worth taking a look at what opportunities already exist in that space. It is not a research study. It is a model test that I think we will learn a tremendous amount through.
And I can tell we're ending, so the last 10 seconds, I just want to address interoperability because I think it's a critical concern as we start thinking about longitudinal measurement. We actually just got a new project funded by CMS with collaboration with ONC to specifically look at the outcomes of interoperability, or the lack thereof, as being a way to start driving this. What could we measure if we had interoperability? What can we not measure because we don't, as all these other efforts are going forward to try to put the bits and bytes together to make it happen? Again, we have to have a bit of a burning platform as well. We can't do X. which we need to do to drive improvement because we don't have interoperability. So with that, I'm going to turn it back to you, Peter, very quickly.
Perfect. We're gonna close this session out. I think, Susan, we'll capture you at the next time. But I want to just thank our panel. It's a very rich conversation.